Hi, I'm Amanda Parsons, the Deputy Chief Medical Officer for MetroPlus Health Plan, and I'm here to tell you today about a multi-partner COVID response strategy. First, I'll tell you a little about what we did, the problem we were trying to solve, and then I'll tell you what we learned from the exercise, and then I'll follow up with next steps. So first, in terms of context setting, MetroPlus, where I work, so we are a health insurance company. Importantly, we're the wholly owned subsidiary of New York City Health and Hospitals, which is the nation's largest public health system. We insure about 500,000 lives across all 5 boroughs of New York City. We're a fairly well recognized plan with a 5-star rating in the 2018 Consumer's Guide. And we offer many lines of business, including Medicaid, Medicare, managed long-term care, etc. Importantly, you'll note that we are over 67% Medicaid, which means the preponderance of our members are vulnerable. They are of lower socioeconomic status and have fewer resources to avail themselves of. The other thing to note is because we have such rich diversity in New York City, reflecting many different kinds of cultures, many different languages, it can be a challenge to reach out to people quickly. And as such, we have a lot of diverse, culturally competent staff who work with our members. So if you recall, back in March of 2020, March 1st, New York State had its first COVID case. And very quickly, things spiraled out of control. We quickly led the nation in both the number of new cases and the number of deaths. And unfortunately, we hold that position still today, and with 23,000 deaths so far. So New York City was hardest hit. I mentioned to you the rich, vibrant culture that New York City has, but one of the downsides of that is there are a lot of people intermingling, and so it's very easy for things that are happening in other countries to quickly impact a place like New York City. Also, I told you about our members, many of whom are very vulnerable. They may live in very overcrowded situations. I mentioned that they have generally lower socioeconomic status, and as a result, a high disease burden. So my team and I had been working to prioritize people that we wanted to reach out to. And so we thought, who would be the highest risk people that we cared for that would be in need of a check-in? And we ran an algorithm using what we knew at the time, which was that people who had comorbid heart disease or lung disease, or who were immunosuppressed in some form or fashion, would be the people who would fare more poorly if they were to get COVID. And so running that algorithm through our analytics team, we got a list of 85,000 members to prioritize for outreach. And the plan was to call them one by one in a very resource-intensive way. Lucky for us, however, in parallel, the New York City COVID-19 Rapid Response Coalition, which was a group formed by Trevor Price of Oxy & Partners. The group was a cross-sector collaboration with leaders from social services, from healthcare and technology, and they were forming together to think about how to provide a collective impact strategy to help with a COVID response. And so we were connected to them, and as a result, we received an incredible service. So we received pro bono project management from Bain & Company, technical expertise and solutions from Amazon Web Services that I'll refer to as AWS from here forward, and social service assistance from AIR NYC, which is a New York City-based, community-based organization who have deployed community health workers to help out for a variety of different issues. So what was it that we did? Well, AWS built for us an SMS-based chatbot solution, leveraging 3 of their technologies: Amazon Pinpoint, which allowed for the globally distributed text service, Amazon Lex, which built a conversational interface, and Amazon Connect, which allowed the people that we were reaching out to through a chatbot to be connected to the services that we wanted to put forward in front of them. Importantly, we didn't want to just send out links or phone numbers or lists of resources to people. We thought it would be far more valuable if we could actually ask if they wanted to be connected to those services and actually facilitate that connection. So we worked collaboratively every morning for 3 weeks in a row to design, deploy, and refine the solution over a 3-week period. And I won't go into all the details of the technology because those are available through a blog that was published, and the link is shown here. putting all the technology aside, the way that we explain this to our team is this is really just like a wellness check-in that we do for our members, either in English or in Spanish. So I talked to you about this iterative design. So what was it that we were iterating on? So the first was to understand what are the needs that are the most important to be ascertaining. So we knew we were, at the time, people were very concerned about COVID. Do I have it? Am I at risk for it? How do I protect myself? My friend coughed on me yesterday. Am I okay? And so we knew we had to identify whether or not they had either COVID symptoms or COVID concerns, and then link them up to a New York City hotline that had medically trained professionals who could answer questions about that and refer people to further care. We were also learning that this was a time where people were rapidly changing their life circumstances. Their kids were going to be at home. Maybe they've lost their jobs. Maybe they can no longer commute to their jobs. And a lot of things were being upended, including this was right in the height of like the run on toilet paper, and people were finding it very hard to access the resources and the services that they needed, which was causing a lot of stress. New York State had developed an emotional wellness hotline, and so we wanted to find people who were really struggling with their anxiety or their stress and be able to connect them to an emotional wellness hotline. We also started to become concerned that people might not have their medications at hand. It may have been a couple months since they had seen their doctor. They may have run out or have been scared to go to the pharmacy to go get new medications. They may not be aware that some of the pharmacies started delivery programs. And so we wanted to find out if people had run out of medications, because while everybody had their eye on the COVID ball, we knew that we couldn't drop the other balls of chronic disease and other issues where these are things, for some diseases, the lack of medication can cause you to have a really, really bad outcome. And so it wasn't just going to be about COVID. We also saw in the market that doctors' offices were quickly shuttering. So obviously, emergency rooms and hospitals stayed open, but a lot of the smaller practices, the onesie-twosie kind of doctors' offices were closing. And we were worried that patients who had other underlying chronic diseases or need to access healthcare for whatever reason would not know where to go. And we at MetroPlus had just launched our telemedicine platform using our vendor American Well. And so this coincided perfectly with us being able to put forward another option for people if they needed to access a doctor. We were hearing also that people were running out of food, unable to go either afford food or find food, and some afraid to wander out. Some could not go out because of their quarantine status. And so we thought it would be important to reach out and to identify if people had run out of food. And we were also learning that people had been applying for the unemployment assistance or trying to, but many of them were finding the site very, very difficult. There were so many people who were simultaneously trying to access those resources that the state website in the beginning was crashing, and people felt like they may not be eligible as a result, or that they were somehow losing traction. And so we thought it was important to be able to talk people through that process. At first, we connected the people who said that they needed either food or help with unemployment assistance or even housing to the AIR NYC community health workers. And after the 3-week phase, it was actually our own social determinants of health care managers that took over that piece of it. And then we said, well, maybe we didn't quite cover all the needs that people might have, and we don't know what those are. So let's just have an other bucket where people could say, okay, yes, I have a different need, and we would connect them to the MetroPlus customer service. So that was a big part of it, is figuring out what were the needs that we could identify and what was the right commensurate resource to match that need up to. There's no point in identifying a need if you don't have an easy way to connect the member to a resource to address that need. We also spoke a lot about which populations were high risk. Was this cohort of 85,000 the right cohort, and how should we prioritize them for outreach? And we also debated, was it better to go wide, meaning to add more high-risk members to this cohort, or was it better to go deep, meaning to repeatedly contact a patient or a member like on a weekly basis, right? If you imagine with a limited capacity, you can either see more people or see the same people more frequently. And so that was the question that we struggled with: is were we going to send out like a chat box? Would it be like a weekly wellness check-in, or was it more of a like one and done? And lastly, we wanted to better understand how were the words that we were using in this script driving engagement and effectiveness. Because we quickly learned that depending on how you worded things, how you ordered those different needs that I just delineated, mattered to how often somebody might say, I have that need and I want to be connected. And so we worked a while to optimize the script strategy. So in terms of the script, this is an example. This is one of the many iterations that we had. But we wanted to come out with a friendly opener like, hi, this is a wellness check-in from your health plan, MetroPlus. We can help you with these things, and we list out coronavirus. We led initially with coronavirus just because that was top of mind and what everybody was concerned about, and then asked about food and unemployment and housing. And then we asked them if they wanted to continue, and if they wanted to continue in English or in Spanish. And then came the series of 6 questions asking more details. So do you need help with food or unemployment or housing? If yes, you get connected. Do you have a fever, cough, or sore throat, or trouble breathing? Or if you're worried that you might have coronavirus, and then connect them to that coronavirus hotline I mentioned to you. Are you worried? Are you having problems getting your prescription medications or refills? And so on and so forth. Each one of those words was carefully selected, and many more were cut out of this to make it more optimized for a text platform. So in a nutshell, in the first 3 weeks of deployment, we reached out to over 54,000 New Yorkers, of whom about 9% engaged with a chatbot, and more than half of those told us they had at least one health or social service need. And of those who self-identified that they had a need, at least half of those engaged, or 56% of them, agreed to be connected to the appropriate service. And I say at least half because there were some points of connectivity that we could not track and measure, most notably those that were connected to the COVID hotline, those that were connected to the emotional wellness line, and those that were connected to our telehealth visits. So in forming those guiding principles, we decided that it was going to be more important for us to reach out to more people as opposed to reach out on a more repeated basis to the same people. In terms of thinking through what we wanted to define as a successful script, we struggled with things like, should it be the number of people who told us they were food insecure, or was it the number of people who said they had a need, or the number of people who responded overall? And we said, well, it's important to get the number of people who respond up, but we want to make sure that the people who are responding are the ones with needs. So we also started tracking the number of needs identified, the average number of needs identified, as a measure of whether or not the script was effective. We did play around with the order in which we would ask the questions to make sure that we were leading with the priority issues, which initially were COVID and then flipped quickly to food and insecurity. And we wanted to make sure that whatever we were doing, that we were able to connect patients. So if somebody said, yes, I have this need, yes, I want to be connected, we wanted to make sure that they actually did get connected. Because depending on the phrasing, you could get people to say, yes, I have this need, but no, I don't want to be connected. And so in summary, for our pilot launch, which spanned from April 2nd to April 27th, the 53,720,000 members that received a text message, like I said, 9%, or just over 5,000 of them, engaged with the chat box. And the 55% of them who identified that they had at least one or more need. You can see 95% of those, the need was, at least one of their needs was social services, followed up with the combination of COVID, emotional support, and telehealth, as well as needing MetroPlus Health, which is when we connected them to our MetroPlus customer service. And then last but not least, the pharmacy needs. And then you can see the stats below of the proportion of those that identified the needs said that they actually got connected to the appropriate service. So for instance, 2,616 people said they had a food insecurity, housing, or unemployment assistance need or a social service need. And of those, 1,456 were connected to AIR NYC. This slide shows our launch calendar, where we initially started with 1,000 text messages that went out on April 2nd using our initial script, and shows you how we iterated that script over several weeks, playing around with the language, moving initially beyond food insecurity to unemployment assistance and housing. Then on April 6th and 7th, we moved that question up to the top. We were able to add in the language differentiator that I showed you about being able to pick English versus Spanish. And then we piloted other sort of variants of the theme. You'll note in terms of the launch scale, we started off with a fairly conservative 1,000 person outreach, just so that we could work on optimizing all the different points of connectivity. And then when we hit our stride, or so we felt, around April 10th, we moved from 1,000 to 10,000 and kept working through different iterations at a much larger scale. And you can see in the bottom over the engagement rate changes, goes up and then down, and we really tried to play around with how to, as I mentioned before, how to maximize that, but then also have people identifying needs and being able to connect them. So this was a bit how the project worked. Now let's transition, and I'll tell you a little bit about what we learned. So the first thing, in order to understand our findings, I'll define for you who this initial cohort was. I mentioned 85,000 people. So 85,000 high-risk MetroPlus members, which at the time we defined as they were either age 65 or had at least one of the following comorbidities, like COPD, congestive heart failure, a history of heart attack, leukemia, cystic fibrosis, chemotherapy, etc. We excluded certain lines of business for this. And importantly, we also needed to exclude people who didn't have mobile numbers. So that 85,000 rapidly became 43,000 people that we could do the outreach to. And so we worked through those members from April 2nd to April 15th. We were also able to pick up another group of high-risk patients based on the 3M risk stratification methodology, which is a third-party risk stratifier, and that yielded about 22,000 members for whom we had the mobile phone numbers for. And we were able to, between April 23rd and April 27th, reach out to just about half of those members. Bain and Company did a really nice analysis for us using the data from the April 10th all the way through to April 15th, which is where we had most of the kinks worked out, and we're sure that we could cut the data by all the different data elements that we had sent over to Bain. And what we learned from their demographics and health characteristics analysis is that the at-risk population that we had reached out to was balanced in terms of gender and age. It skewed towards minority racial groups and English speakers. In terms of the engagement and connection rates, those we did see some differences. So notably, the age cohort with the highest engagement rate was the group between 34 and 64 years of age, which surprised us because we had thought that perhaps the text platform would be more appealing to a younger cohort. But interestingly, the under 30 population was less likely to engage and connect with the SMS chatbot, which suggests to us that maybe we should be thinking about a different mode of reaching out to them in terms of maybe more web-based or social media-based, etc. We saw that our Spanish-speaking members had much lower rates of engagement than the English-speaking, and that indicated to us that we really needed to lead with a Spanish introduction for those who spoke Spanish, as opposed to just using the English introduction and then asking people if they wanted to continue in English or in Spanish. And so AWS was working with us on how to even right off the bat lead with a Spanish only script. Interestingly, the members who had high rates of inpatient and emergency department visits, or 3 or more visits in the last year, were much less likely to engage, 20% to 30% less likely to engage, suggesting that those are some of our highest risk members, and yet they're not easy to get a hold of. And we know that sort of anecdotally through our own care management, but it was interesting to see that reflected in the engagement rate with the chatbot. In terms of what people self-identified for as their needs, we also saw some demographics. We also saw some variation by demographics there. So the middle-aged to younger age cohort, so those who are less than 40, were more likely to identify social service needs. So remember, that's the food insecurity, the unemployment assistance, or the housing. The older population, the 50 and older, they were more likely to identify a health-related need. And then the sicker people were, so the more diagnoses they had, the more likely they were to identify any need at all. So the goal of this project, if you remember, was to find people who were struggling and needed help and to connect them with help. Initially, when Air NYC, the community-based organization, was receiving the calls, it was harder for us to get an appreciation of the difference that this was making. But after the 3-week pilot I mentioned, our social determinants of health care managers took over addressing the concerns of members related to those social service needs. And in that process, we learned some of the incredibly touching stories of our members' lives. So these are 2 of like hundreds of quotes and stories that are available from this project. So the first is Lenora. She is a domestic abuse survivor. She was living in a homeless shelter at the time with her 2 sons. And she told us, "I was at my lowest, so down and out emotionally, I'd lost hope. When I saw that text from MetroPlus, it was amazing. Somebody does care. Somebody is reaching out. They are concerned about me. So I sucked up my tears and reached back out to them for help. And now I'm working with one of their housing specialists to see if maybe they can find me and my boys a new home." Another is Servia, who said, "My situation was really, really bad. I'm a driver, but I needed to stop because I couldn't risk my baby's health during this pandemic. When I got the text from MetroPlus Health, I was surprised very pleasantly. I think MetroPlus really stepped it up." So importantly, Servia is an Uber driver and she's pregnant with her first child. And so was incredibly concerned about both exposing her unborn baby to COVID, and so had to stop working, but also she was starting to get together all of the materials and all the supplies needed to raise a baby, including securing food and diapers and formulas, and had no way to do so. And so our care managers helped her get connected to those resources. So these are some of the really, like I said, some of the highlights of the work. Importantly, in the morning, we'd start off with the technical team talking about how we would launch for the day and what was the script, and it was much more sort of operational. And at the end of the day, I had the chance to do the end of day call with the community health workers who would tell us what all of the cases that they had gone that day and what they were doing and whether they were having any issues identifying resources for patients or whether they needed any help from other members of the team to do so. And so I have to say it was wonderful to see both the operational, technical, and programmatic side, but also the care management, person-centered, care-focused aspect of this. And it was an incredibly rewarding experience. And so in terms of next steps, I talked to you a little bit about how what we learned from the engagement rates. Like we learned that the connection rates were lower for the younger cohort. And so we are thinking about how we can replicate something like this on different platforms. We are hoping to be able to launch a Spanish-only introduction so that we can recapture that vulnerable segment, the 30 to 40% lower connectivity that we saw in the Spanish-speaking. We know we have to find another way to reach out to the people who are frequently using the inpatient setting and the ER or the emergency department. And so that's also something that we're thinking about now. And then in terms of the need rates, is really trying to understand, why is it that the younger cohort is identifying more social service needs than others, and how can we make sure that they have adequate resources, and how do we use the learnings from this to continue to tailor the project and the principles of the project to meet the needs of the demographic groups that we're reaching out to. Looking ahead, we continued past the original pilot and have reached out to over 80,000 members. And importantly, now are starting to re-engage the initial cohort to see how have their needs changed over time. We are also looking at how we continue to scale this solution to new populations. We had eliminated from the initial cohort members younger than 18, and so need a way to think about how would we outreach to children and their parents about the children to be able to ascertain their needs as well. What are the ways that we can continue to tweak the language, and so we can optimize the outreach, as I mentioned before, and making sure that we have our eyes on the downstream services that we're connecting to. So for instance, if something happens to the COVID hotline, right, we want to make sure that we're not continuing to ask people about COVID related issues and then connecting them to a hotline that doesn't work. It could also be that maybe the hotline continues to work, but that's not the right place for them to get their information from anymore. So we need to continue to monitor the macro environment to make sure that we're pointing and steering people to the right places. It could also be the case that people's needs would change and that we need to start reaching out about a new kind of need that might happen. So in a world where transportation for some reason, shuts down and they have to take like the subway offline or something, massive, we would quickly want to make sure that we're making sure people can get to the places they need to go in a safe and secure manner. So we want to continue to monitor what's happening there. And then really keep an eyeball on other needs that are coming about as people go back to work or not. Or start to go into the summer months, potentially with fewer resources to pay for things like electricity and air conditioning and cooling. We might have to be looking out for those other needs as well. So that's where we stand now. But importantly, I want to note that what I have just presented to you is the culmination of a lot of people's dedicated time and effort, most of whom, but not all, are listed on this slide today. And for me, that has been one of the best parts of this, is to bring together all of these people and really work on an important project like this, leveraging a technical solution to solve a real world problem. And so I'm deeply, deeply grateful for all of the technical expertise that we got from AWS, all of their assistance in designing the solution, as well as the formidable insights we got from other members of the team, like the Air NYC leadership and their community health workers, as well as the Bain & Company team that was working with us, our own technical team. And importantly, the project, I really feel, was enriched by the real world impact on these members' lives. And so it has been a wonderful, wonderful project to be involved with, and I'm so glad I had a chance to tell you about it today.